Hello, everyone. Good morning, good afternoon, and good evening to you all. Or maybe I'll just generally say hello to you all. My name is Alice Kayongo. I work with the Center for Global Health Policy and Politics, based at Georgetown University's Schools of Health and Law. Welcome for joining us today for the DEC webinar series. And by DEC, I mean DEC, which is the Diagnostics Equity Consortium, an initiative that brings together civil society, affected communities, and experts to advocate for better diagnostics access, and most particularly diagnostics access in low and middle income countries where health systems need our support most. At DEC, we seek to reshape the diagnostics policies. We seek to improve healthcare practices and to monitor progress through advocacy, research, and community-driven initiatives. So in a nutshell, as I have always said, you can think about the DEC as a civil society team of superheroes in the diagnostics world. Superheroes minus the capes, but then bring in a spice of community power and the power to save lives. And the best part is that means that you and I truly constitute the DEC, which means that we are indeed superheroes. So as we start off the webinar today, please know that you're superheroes in the fight for equity in diagnostics. DEC is proudly hosted by PATAM, the Pan-Africa Treatment Access Movement, and the Center for Global Health Policy and Politics, based at Georgetown University's Schools of Law and Health. And our mission today is that first of all, we are working collaboratively with a couple of partners, including the Global Fund and ASLM, and we are bringing to you this webinar series on the Speed Up, Scale Up testing campaign. We usually refer to this as the SUSU campaign, just because who doesn't need a catchy acronym for an initiative? And that is why we refer to this campaign as the SUSU campaign. And our objective is to basically bring together communities and civil society members to raise awareness, to build literacy on TB diagnostics, and ultimately our goal is to foster robust and informed engagement and advocacy for planning and scaling up TB diagnostics packages as part of the National Diagnostics Network. On my lineup today, I do have a packed program for the next 90 minutes. We will have a couple of presentations. We will have a short recording. And we will have country case studies. We can never finish up a webinar without having case studies on what is happening in real life at country level and at community level. We will also have interactive sessions where you are not only welcome, but you are encouraged to pose your questions for clarity. You are encouraged to seek more information, but also you're encouraged to add your insights to the conversation. And as always, our role is to connect you with the experts who will guide us through the issues, the facts, and realities, as well as the expectations. Each segment of today's webinar is very important, and collectively they will lead us into our next webinar that is scheduled for October 2nd, but details on that will come in much later. I just wanted to mention that you truly cannot afford to miss any single segment. And remember that we are building towards another session that will be held on October 2nd. More on that to come in later. But for now, let's begin. And without further ado, I want to introduce our first presenter, Sharon Ann Lynch, who is the co-director at the Center for Global Health Policy and Politics, and is also one of the key leaders of the DEC initiative. Sharon Ann, over to you.
Thank you, Alice, and hello, everyone. Thank you so much for joining. The topic of today is the need to close the deadly TB gap, and by maximizing the tools that we have and some of the new and emerging diagnostic tools. This includes a near point of care test, where there are a couple of options in the pipeline and already one that is outside the pipeline and soon to be available. You'll hear more about the details of these tests, but from an advocacy point of view, I'd like to stress the opportunity. The opportunity to test more people, to get them on treatment earlier, and to close the deadly diagnostic gap. We can do this if we are able to use near point of care tests as close to the community as possible at the primary healthcare level. But we also have an opportunity, as we do with any new tool, to make the case to government that we need ambition and we need accountability. We need ambition in terms of having these new tools reflected in a roadmap. There has to be a plan for their introduction. We also need to have ambition so that we can expand the testing coverage, the capability of health facilities to be able to test for TB and the drug-resistant forms at more levels of care and more facilities. We also need to have that reflected in the National Strategic Plan and as well in the funding request for the Global Fund Grant Cycle 8 that is upcoming. All of this matters to close the diagnostic testing gap, which, as I've said, we know is deadly. But there's also the context that we're in right now of the funding crisis. So we don't mean to sound naive. We know that governments, it will be difficult to convince them to be ambitious at a time of the funding crisis. However, it's important to know that these new tools are more affordable than our current molecular diagnostic tests that are widely available. But the limiting factor is they do not at this time provide drug resistance testing. Still, you can have what is called reflex testing, where you test using the more affordable near point of care test, and then you send sample for anyone who tests positive for the testing for drug sensitive TB. But we'll ask WHO to get more into that. And we have, as Alice said, a panel of experts and those with experience both monitoring and doing advocacy to close that deadly gap. Thank you so much for joining, and back to you, Alice.
Thank you so much, Shernan. And with that, I will not even try to repeat what you have said because it has been very clear. I want to move on to Tapiwa Nashe Kujinga, who's the director of the Pan-Africa Treatment Access Movement, which is co-hosting the Diagnostics Equity Consortium. Over to you, Tapiwa.
Thank you so much, Alice, and good morning, afternoon, and evening to everybody. Thanks for joining. Next slide. So I'm talking about the state of the TB diagnostics gap in the African region. As you know, TB is one of the leading causes of mortality globally. Treatment is available, and we now do have more potent treatment regimens that are shorter than what used to be available. But still, we still have a problem with TB globally. So when you go through the 2024 Global TB report, you will find that there was a mortality of 1.25 million people in 2023, and that's quite a lot. 10.8 million people globally newly infected with TB, 6 million men, 3.6 million women, and 1.3 million children. And that's still a lot. So the more efforts which are being done, we're still getting more TB infections. And of that, Africa accounted for 25% of the global TB deaths. With 2.5 million people falling sick from TB and 424,000 dying from the disease. So Africa, has got an unequal mortality burden of TB. But, if you look at it from the lens of the TB burden of people infected. And the global gap between the estimated number of people developing TB, those are the incident cases, and the reported number of people newly diagnosed with TB, those are notified cases, those are people who have actually been tested and have got confirmed TB, narrowed to a best estimate of 2.7 million in 2023, and that's down from about 4 million in 2020 and 2021. So that's good news and bad news at the same time. This shows us that we are doing quite a lot to, track down TB. And the number of people who are being tested and diagnosed is actually, going up. But at the same time, we do have quite a lot of people who are, not being tested for TB. And that's the worry. That's the issue that we're talking about today. Next slide. And so we have got a global commitment towards ending TB. And that's an ambitious target which needs a lot of work towards, ensuring that everybody with TB is diagnosed and is linked to treatment and care. And those are the efforts for ending TB have accelerated over the last decade. We've got a current target for ending TB in the year 2030. And we also have the 2023 Anger Political Declaration on TB, where the commitment is made that by 2027, at least 90% of people who develop TB are reached with quality assured diagnosis and treatment, with all those diagnosed having been initially tested with WHO recommended rapid molecular tests. And so when you look at where we are right now in 2025 and 2027, it's just 2 years, and a lot has to be done to ensure that that 90% target is reached. And by 2030, we've already closed the gap. And the declaration further calls to scale up financing and research to develop and introduce rapid point-of-care diagnostics, including drug susceptibility testing. Next slide. So diagnostics are really key towards ending TB. So these are the global targets set in 2023 at the second UN high-level meeting on TB. And you will find that the coverage of rapid diagnostics testing for TB, which is the percentage of those diagnosed with TB who were initially tested with a WHO recommended rapid molecular test, should be 100% by 2027. Again, very ambitious given the 2-year timeline we're talking about. Next slide. And so that is a map which shows the TB hotspots. Obviously, the epicenter will be Asia. But when you look at Africa, we've got quite, a significant burden in Nigeria and in the DRC. But again, when you are looking at the fact that Africa carries 25% of the mortality rate, it actually shows you that we do have a significant problem with diagnosis, treatment, and care. Next slide. So this slide is from the WHO Global TB Report for 2024, and it was adapted in the TAG pipeline report for TB diagnostics for 2024. I would really love you to have a look at both reports. I'm sure most of you, have gone through them. But the data shows the significant gap between people diagnosed with TB against the estimated number of people with TB. And the African region is at, that first box talks about Africa. The green line is the estimated number of people with TB, and the black line is the number of people tested. And when you look at that gap, you see that Africa has got a lot of work to do, in tracking people with TB, testing them, and diagnosing them. So these data reflect the TB diagnostic gap that needs to be addressed in order for people with TB to be enrolled into treatment and care. Next slide. So what leads to the TB testing gap? Again, we've got this global map from the 2024 report and the TAG report as well, which I've cited previously. So when you look at the countries which are doing well in terms of TB testing, you will find that in Africa, most of them are in, or all of them are in Southern Africa. And the other ones are, at a level which is not really there. So globally, only 35% of diagnostic sites have got WHO recommended diagnostics for TB. And lack of tools for community diagnosis of TB leads to gaps in care cascade. And then we also have got the issue of the price. Most of you, if not all of you, are aware of the ongoing issues between treatment activists and Cepheid in terms of, or Danaher, in terms of reducing the cost of the Gene Expert cartridge so that, the test for rifampicin resistance can reach as many people as possible. Next slide. So, missing TB patients. This is an interactive country group dashboard from the Stop TB Partnership, and it's actually talking of Africa. And you will find that these statistics will tell you of missing people with TB. It's estimated in Africa around 670,339. And missing people with drug-resistant TB, 38,182. What's worrying is that these missing people are not only developing active TB, but are also a source of transmission, and that actually compromises the TB response. Next slide. So how do we bridge the testing gap? This slide will tell you about what needs to be done. So there is need for more molecular testing, right? As compared to microscopy, right? There is need for decentralized point of care nuts as compared to centralized laboratory-based nuts. There is need for multi-disease testing, right? Where you've got multiplex diagnostics as compared to single disease testing. And we need more non-sputum samples. For example, oral swab urine. Now they are available. We do have assays which have got better specificity and sensitivity, and those should be deployed. We also need testing to be closer to communities and homes. We need active case finding and pre-care seeking, as opposed to healthcare facility-based passive care case finding, because you don't need to wait for people to come to you, but you go to the people. We need to focus on yield and population coverage, as opposed to focus on test accuracy. And finally, we need lower cost, higher volume, and LMIC manufactured assays as compared to high cost, low volume, and high income country manufactured assays. Next slide. So one issue that really came to, which I discovered when I was researching for this presentation, is the unacceptably high number of people with HIV who are diagnosed with TB post-mortem. And these are all studies from cadaver studies where people are, tested for TB after they've already died. And these are people who were either asymptomatic or not tested or treated for TB before they passed away. And the results are quite shocking. Next slide. So you will find that we know TB prevalence is higher in people living with HIV, and postmortem data, as I've said, shows high level of undetected TB in people living with HIV. So in one retrospective study the prevalence of TB in cadavers, that's dead bodies, was 63.2% in South Asia, 43.2% in Sub-Saharan Africa, and 27.1% in the Americas. Very high. These were people who were not known to have TB, but they had TB and died before being tested and treated. So there is need to ensure that everybody with HIV is also tested for TB. And again, worryingly, TB in adults was disseminated in 87.9% of the cases and was considered to be the cause of death in 91.4% of TB cases. And that's also very, very worrying. More work needs to be done amongst people living with HIV to ensure that, they don't proceed to active TB as well as death. And next slide. Thank you. So that's my presentation. And I stress that together we can end TB. Thank you for listening. And back to you, Alice.
Thank you so much, Tapiwa. I think it's getting interesting now that we are, diving deep into the statistics and seeing where indeed the gap is not only in the Africa region, but also globally. And Tapiwa has made very good points, and he's directing us on what exactly we need to do. So that being said, I want to bring in Alexei Korobitsin, who works with the WHO, and Alexei is going to take us through the WHO policy advances towards universal access to TB diagnostics testing. Over to you, Alexei.
Thank you very much, Alice, for an introduction. Good morning, good time of the day, I should say. Ladies and gentlemen, and this is my pleasure to be today an honor for this important event and of audience of utmost importance. I'm sure civil society has a lot of power already used, but maybe more and still more possibilities and capacity to use. And I fully agree with Alice calling you superheroes. Just we all need to believe in ourselves. So my presentation today will focus on WHO policy advances towards achieving universal access to TB testing. And this is next slide. Already, WHO policy advances starts with promotion and advocacy of universal access to testing. So it starts with NTB strategy, the baseline documents for TB control globally, fight against TB globally, and a background and baseline document for all of us, I should say, who works in this field. And pillar one of strategy, NTB strategy, which is located within integrated patient-centered care and prevention, highlights the importance of the early diagnosis of TB, including universal drug susceptibility testing. What does it mean, universal drug susceptibility testing? That means that all people with presumptive TB, there is definition of presumptive TB, there is a cough and other symptoms, several other symptoms, receive initial WHO recommended rapid diagnosis for TB, or otherwise called WRD. So the strong sides of this test is that it is accurate and rapid. And second part of this definition of universal drug susceptibility testing is that WHO recommends that all people with TB are tested for resistance at least to one first-line drug, rifampicin, which is most powerful, and also resistance is relatively easy to take comparing to other drugs. Not to say it is nothing to do, but many tests, luckily, unfortunately, can do this. So that's because there is no excuse that person with TB, with diagnosed TB, is not tested for rifampicin resistance. And those with detected rifampicin resistance, this is last part of definition for universal drug susceptibility testing, all these detected rifampicin resistance should be tested for resistance to fluoroquinolones. It's another drugs also powerful and also this very possible to detect resistance. And again, there is no excuse if a resistance is not detected. Next slide, please. Next part or another side of advocacy is global advocacy for early and universal testing is global TB report. Already my colleague Tapiva mentioned it. I will just briefly highlight that it presents several gaps. First gap is that 2.7 million of people lost with TB disease. They are not notified. According to estimations, they do exist, and this estimation is based on mathematical modeling. But they are not notified. There are usually two reasons why they are not notified. They are either not detected at all, which is the worst case, which means they go among us and can disseminate TB and can infect others. And second reason can be they are detected but not notified. It's also not ideal, I would say, because there is a less possibility that these people will get treated effectively, and so it's just also not good. So this is the first gap. Second gap is that only within those notified, only 48% are notified with WHO recommended rapid diagnostic, which means accurate and rapid tests. Excuse me. So why it is bad? Because it was required likely more time to detect these patients, even so they are detected. But then they may be detected by mistake, or they don't really have TB, have other diseases, and maybe they treated wrongly. So the difference is not all. I mean, some of them not bacteriologically confirmed. At least there may be others we detected with microscopy, but which means less accurate test and more complicated test, so to speak. It's good that these people are notified, but they are not. This is not optimal that they are notified without using WHO recommended test. And last gap is that of those using WHO rapid diagnostic test, only 79% got results for rifampicin resistance. As I mentioned previously, this is part of universal drug susceptibility testing definition, so there is no excuse for it. I really cannot justify it. Next slide, please. And this 48% of access to WHO recommended rapid molecular test globally, but there are two things to retain here. First, that there is an interval from 80% in European region, which is very good, down to 40, which is in Southeast Asia region. And overall it gives 48%. Again, and also in two regions, Eastern Mediterranean region, Western Pacific region, unfortunately, there is a decline. Right? I understand most audience is from African region, so there is no decline, it's already good, but it's not as high yet as 80% in European region, so there is something to improve. But overall, I think it's not bad, but not yet to be satisfied. Next slide, please. These are principal documents for WHO advocacy on rapid and early access to diagnosis. I will briefly describe some of them and focus on two which are in the center, which are highlighted in red sort of border. These are advocacy documents, and the rest is starting from orange color. This is screening guidelines. It gives WHO recommendations on screening, which is related to diagnosis, but not exactly, right? Screening is done among healthy people who cannot be defined as presumptive TB cases. It's just within community. Second document in blue, dark blue, is this list of mutations. This is more for reference level laboratories to, when they find unknown mutations and they want to know what this mutation means, they check it against the catalog. On the right, there are two documents, WHO guidelines and WHO operational handbook on diagnosis, right? Diagnosis is in green, unlike from screening, different from screenings, which is in orange. And WHO guidelines on diagnosis, they provide set of recommendation and evidence underlying this recommendation. So briefly, to characterize this document, one can say WHO guidelines say what to do in order to diagnose tuberculosis. But this is not enough to know. There are many conditions and many particularities in it. So second document, WHO operational handbook, it says how to do it. And in total, they represent, there are around 10 diagnostic classes, there are 25 technologies, and around 20 recommendations on diagnosis. Next slide, please. And this is one of two documents which particularly are intended to be used on advocacy. The first one is called WHO standard for universal access to TB testing. The objective of this document is to improve access to use of WHO recommended rapid diagnostic testing as the initial test. So how it is organized? It is organized along the sequence of events for the diagnosis. Otherwise can be said as a diagnostic pathway of a person with presumed TB. The first step, identifying presumptive TB. Second step, accessing testing. Then third step, being tested. And fourth step, receiving a diagnosis. So there are 4 steps, and each step has several benchmarks. What is benchmark? Otherwise, benchmark can be called an indicator. And each indicator or benchmark gives a particular picture of a certain aspect of within this step to characterize how the system is ready for implementation of this test. In other words, WHO recommended molecular test, which is advocated by WHO for all patients and all people with presumptive TB. And together there are 12 benchmarks. They give a comprehensive picture. For example, the very first benchmark is related to identifying presumptive TB, is not directly related even to testing with molecular tests or rapid diagnostic tests. It asks whether all relevant risk groups, high risk group for tuberculosis, are properly screened. If yes, then there is a basis for effective diagnosis, which should follow ideally. In practice, it's not always the case, but if no screening at all exists, then it's very difficult to imagine effective diagnosis. I mean, it's also possible. I cannot say that. I don't say that this benchmark is solution for everything, but this is like a brick. You can imagine there are 12 bricks, and if they are all put together, then it works. Molecular tests are available, and if one brick is not there, then it still can work somehow, but already not perfect. But if then imagine half of the bricks are not there, then it's very imperfect, to say modestly. So the second step, access to the testing, is more related. So it says one benchmark says, for example, whether all healthcare facilities, primary healthcare facilities, are equipped with technologies, and so on. So as I already was trying to say, so altogether, they represent comprehensive picture. Next slide, please. And another chapter, particular chapter of this document, it presents barriers and enablers. Again, around these 4 steps. And for example, the steps related to access to testing, this is step related to patients. So on patient level, there can be several barriers, but also several enablers. So I will not go into detail, but you can read it yourself. Just short example, direct costs can be barrier, but also enabler that technology can be readily accessible and close to the patient is enabler. And again, they are organized around these 4 steps, and whole document is very logical in this sense. Next slide, please. So next document really useful for advocacy is called Target Product Profile. Target Product Profile is a document intended for manufacturers, first of all, but also to researchers and other people interested and working into the promotion of diagnosis. That the new test diagnostics became available. This document gives us standards or benchmarks for the new diagnostics which should become available. In last year, in 2024, the document this document was published, and it has 2 parts. First part was republished. Actually, it was developed a few years ago, and it is focused on it is focused on next generation TB drug susceptibility testing. So it is level of health facilities. And it is level of GeneXpert, to say more clearly, and it gives for, let's say, for competitors or for successor of GeneXpert, it gives certain benchmarks. For example, that fluoroquinolones can be included, then target population can be also expanded to test all ages. Now it also can be used in children, but in children it is less accurate. So to speak, new technologies should become more accurate. And next slide, please. And a really new, let's say, chapter is the target product profile for peripheral settings. There are 3 classes which are presented and briefly described. These are classes of point of care, near point of care, and low complexity. Low complexity already exists, and point of care and near point of care is not really existing, but is prospective. Yes, I'm about to finish, Alice, right? Next slide, please. Is give examples of characteristics. There are about 40 characteristics, and there are some presented here, but I will not go into this. This is an example, like intended purpose and target population. Next slide. And also diagnostic accuracy, minimal requirements, optimal requirements, also depending on a sample. With sputum should be more accurate, with non-sputum sample less accurate. Next slide. And this is credit to Martin Ruwald, who will speak next. My colleague for many years from FIND. And he will speak in more details on this. I only present priorities. Next slide, please. Yes, this is priorities and future directions from sputum to non-sputum samples and from laboratory based to non-laboratory based technologies. Next slide, please. And this is in more details, again, of new technologies. I believe Martin will present much better than me. This is near point of care technologies. Next slide. And to summarize, what should be next steps to promote universal access, to continue collecting, monitoring, supporting countries, coordinating experiences and success, sharing of experience and successes, disseminating documents, and supporting other activities, including survey. Next slide, please. And acknowledgement to my colleagues and to chef the team, the diagnostic team, head of diagnostic team, Patricia Hall-Aitson in particular. And this should be all. Next slide, please. Thank you very much for your attention, and I'm happy to try to answer your questions to the extent possible. Thank you very much. And sorry for going probably a bit over reglement.
Thank you so much, Alexi. We indeed needed all this information, and we appreciate your time. And thank you so much for stressing some of the statistics that Tapiwa introduced us to. We clearly see where the gap is, but we also appreciate the guidance that is being provided by the WHO. To our participants, please feel free to ask your questions in the Q&A chat, post them there. Our panelists will be happy to respond to them because, as you know, time is just never on our side. So please make use of the Q&A chat to ask your questions and you will get responses. So I want to turn over to a colleague from FIND, Morten, who we actually don't have Morten live, but we do have his presentation that will be running shortly, and Sharanan is helping on that side. Thank you.
Sharanan, I think you'll have to unmute yourself so that we can hear you.
Tools that opens some new opportunities. And as mentioned several times here, the diagnostic journey, or the journey from the patient who is experiencing symptoms, that journey to get a good diagnosis is long and complicated. And see if I can get my slides. Often at the primary healthcare level, there is really no diagnostics available for TB. What we are using predominantly is a sputum sample, which is a complicated sample to obtain from many patients, and it's not a complicated sample to work with. And run a test on a sputum, like a modern molecular test like the GeneXpert or the not very sensitive but still highly used smear microscopy, it requires a big laboratory like this, which is rarely available at the primary healthcare center level across the world. So at FIND, we are supporting manufacturers, academics, and countries to kind of identify and develop the tools that are able to bridge these gaps. So ideally, we would love to have a test that is incredibly accurate, very sensitive, very specific, should come in at a very low cost, should be sustainable, not polluting the environment, and be safe. And then we would like to have a diagnostic that can diagnose many other diseases on the same platform. And of course, we're not going to get that, at least not to begin with. So figuring out the trade-offs between these technologies is important. So Patricia mentioned the modeling exercise that is sort of shaping our thinking on how such a modern new test should look. And in this example here, we have the big box here, and that is the number of the total population of people in need of a test. And currently, the tests we have are only reaching a small population like this blue box. And that is because the sputum sample is difficult to obtain. The journey to go to a place where the tests are is long, and people drop off on that way. So, in that box, that is currently where we can improve on the performance of the tests. So what we're trying to do is to have tests that are so simple that the box becomes larger. And in this example here, we go from 25% access to 75% access. And you can see the box, of course, is way bigger, which means that you don't need to be as accurate to diagnose more people. So here you can see the green box is those that are correctly positive, and then the blue box here correctly negative. But the false negative tests, you can expand that quite a lot and still retain a larger area than with the not so accessible tests. Let me give you some examples. So we're trying to go from a sputum sample and a complicated lab-based test to something simpler like tongue swabs and a small portable PCR machine like this one from PlusLife. And we have done some studies to demonstrate that if you take the diagnostics to where the patients are seeking care, you are actually able to put people on treatment very rapidly. And this is a study, the TB CAP study, which was led by FIND, where we were looking at putting the MolBio diagnostic, which is the made in India competitor to GeneXpert, you could say, that at the primary healthcare center in a couple of sites in Tanzania and in Mozambique. And we demonstrate by having a diagnostic available where patients are seeking care, we are actually able to get the vast majority on treatment. And that's what we're illustrating here with time, standard of care. That is the usual way of diagnosing TB. And here, the intervention where we place the diagnostic where they're seeking care, the vast majority actually get on treatment the same day. And we know that is important to ensure that there's no drop-off, that also the patients feel that their disease is being taken care of here and now. And that's the idea we want to go to, demonstrate it here, that actually with the tools we have, we can make that happen. But with these new tools like a swab-based diagnostic, we can do more. And this is a study, apologies for the complex slide, but this is a study we participated in, led by the Desmond Tutu Health Center in the Eastern Cape in South Africa. So here they were going from household to household to do active case finding and household contacts. They visited almost 450 households, and they identified almost 1,000 household contacts in this interim analysis. And by knocking on people's doors, they would get sputum from only about 293 of these almost 1,000 household contacts. The remainder were unable to produce a sputum sample. However, they got a swab sample from almost everybody, so 98%, suggesting that that sample is actually easy to obtain in this population. Of course, sputum there's more bacteria in the sputum, so the positivity rate out of those was higher. So 10% here had a positive sputum, where only 7% had a positive tongue swab-based test. But you could see the diagnostic yield here. The population is wider, so we can diagnose more people with a less sensitive test. It doesn't matter that much. And you can see, so here the diagnostic yield, sputum alone, you would diagnose about 3%. Swab alone, diagnose 6.4%. And then if you say, we take the sputum from those who can produce sputum, but those who do not produce sputum, we can do a tongue swab. It is 6.7%. So there were an added value here of 32 people out of those 664 who could not produce a sputum that actually tested positive on the swab assay. And we are very happy to see these kind of data coming in as a proof of concept. And importantly, the healthcare workers who were leading the interventions here, they managed actually to link 86 of these to care with a median 1-day time to clinic presentation, also illustrating the impact of an intervention like this. But let's look at some of the technologies that are in the pipeline. So here, this is the TrueLab from MolBio Diagnostics in India. Here they are accepting either a tongue swab or what they call it's a sputum sample, but instead of running the sputum sample, you dip a swab in the sputum. So the sample is the same. It's a swab that goes into the assay here. You put it in a little vial, you break off the long part of the swab, you put it in a small machine here that within a couple of minutes disrupts the bacteria and exposes the DNA. And then you can pipette it into a little vial, and that requires a little bit of incubation. And from there, you pipette it onto the diagnostic test itself, and then you run the test. The time to result here is about 40 minutes, which is faster than what we're seeing with the currently available tests. The hands-on time is less than 5 minutes. This is a battery-operated diagnostic test. They are targeting at the moment an $8 cost per test, and it is still an expensive device, about $10,000 for the MolBio test. Another version of this concept, I just wanted to highlight that I'm in South Africa at the moment with Adam Penn-Nicholson, who's the Deputy Director of the TB program. We were visiting some of our colleagues who are working hard to generate the evidence to demonstrate the performance here. We were seeing here at the in Grant Theron's lab at the Stellenbosch University that this was up and running, which was really encouraging to see. Okay, so this is another example of how a test could look or is looking. So here, they're again either taking a tongue swab or a sputum sample where you dip a swab in. You put it into this really, really nice little bottle where you then, a little bit like we are doing with the rapid test for COVID, you're then releasing the DNA through chemical lysis. That happens on a device like this. And then afterwards, you basically drop a couple of drops of your sample here into this card that goes into a very small machine, and rapidly after you get a result. So they claim the time to result here is about 35 minutes. Hands-on time, 2 minutes. It's battery operation possible here with the device. They claim the cost per test is way lower, down at $4 per test. And I think what is really going to be disruptive here is the cost per device. So this machine here is a $150 instrument. So here at this price, if the machine breaks down, you don't have to wait for the repairman or repair person to fly in from Germany or wherever they come from. Here you basically just take another machine on the shelves because the cost is so low. And at the same visit to Stellenbosch, we saw how they're also using this to generate evidence. Here they had 2 of these licensed machines and 4 of these instruments lined up on this docking station, you could say. And yeah, they are quite happy with this test also. So this is real. This is happening now. And there's several other diagnostics in the pipeline that have similar form factors, you could say. And interestingly, several of these are actually made in the Asia-Pacific region. And you can have another sort of dimension to this if you have a mass screening campaign where you go into the communities with healthcare workers and try to, for some, where you send out tongue swabs to in the population. You could then have high throughput analysis, and this is an instrument that is being, or the workflow that is being developed for TB at the moment. So here you can have like an automated mass swab handling machine, and then you can put it on this, it's called the Nexar machine, which is a high throughput PCR machine that can run up to 150,000 samples in a single day. It uses this assay tape, and there is a barcode from basically from the time of the swab to the analysis result, making it really easy to send the result back to the healthcare worker or even the patient or the person being tested themselves. And this could potentially open up for self-sampling for TB if this instrument and high throughput system works. And I've spoken a lot about these tools, these point-of-care molecular devices that are in the pipeline, and I don't have time here to go into details on other technologies, but I just want to show you here the instrument park of some of the new tools that are in the pipeline. We have in the low complexity NAT, so that's the group that is currently dominated by Cepheid and MolBio. You're seeing many other tools coming in here, and many of them actually offer broader drug resistance testing. Isoniazid is coming in as a industry standard, you could say, which is fantastic for all the isoniazid monoresistance we are seeing in many countries. Also, there are higher complexity, moderate complexity, the bigger machines that can do more. Several more samples analysis in a single run is also a growing area here. And then, as Patricia alluded to, we have several machines also on the targeted next generation sequencing that is happening, which is really important, necessary tools to somehow better manage the increase in drug resistance we are seeing across the world. So I would like to just finish off with a couple of take-home messages. I think we live in times of really accelerated innovation. Many of these new instruments are coming online now. I've showed you how they are real and under evaluation here in South Africa, but across the world. And there are many new instruments, many new sampling strategies that are showing promise to bring the diagnostics closer to where the patients are seeking care. We expect to see a drop in sensitivity, and I perhaps should have spoken a little bit about that. We're seeing perhaps a 5, 10, 15% drop in sensitivity with these tongue swab-based approaches compared to what we are seeing with a standard sputum. But that trade-off, because it's an easy accessible sample, I think is something we can live with. But that is big gap. We need to generate that evidence to help Patricia and her team to make the right policy decisions. There's a busy pipeline, and that calls for a lot of collaboration and coordination to assess the new products. And we are seeing massive impacts of the US government decision. And expand on
Hello, everyone. I'm Agrita. I work at Center for Global Health Policy and Politics, and I'm a member of Diagnostics Equity Consortium. And I will be providing some updates on oral swabs and near point of care TB diagnostics. I'll be framing these updates within the 5 indicators developed by Broger et al. As shown on the top of this slide, as we know that simpler samples and testing nearer to people can improve uptake of diagnostics, something that we saw in the video. So I'll be focusing on the oral swabs and near point of care tests and what they're doing exactly. So they're critical to improving the diagnostic yield, and I'll be focusing on Molbire's MTB Ultima, and then the Plus Lives Mini Doc. In terms of samples, though TrueNat uses sputum, but TrueNat Ultima and Mini Doc, they're using oral swabs also as samples, which are obviously simpler to get. And then both are battery operated and do not require a constant source of electricity. The turnaround time for both is below 1 hour, and it's just 30 minutes for Plus Life. More interestingly, the hands-on time for Plus Life is just 2 minutes. Further, as you can see, TrueNat is a WHO recommended rapid molecular diagnostic, while Plus Life recently received the Global Fund, the ERPD approval by which it can be taken up by Global Fund. And then, so we know, that they meet the 3 indicators. That is, it's user-friendly, it has rapid turnaround time, and oral swabs are obviously easier to access than sputum expectoration. So on to the next slide. In terms of robustness, when it comes to oral swabs, one of the most recent results from Amy Stedman's study is that is undergoing peer review. It is based on the study that this group R2D2 conducted on adolescents and adults aged 12 and over with presumptive TB from outpatient health centers in 3 countries, India, Uganda, and Vietnam. In this study, 2 tongue swabs and 2 sputum samples were collected. These samples were then evaluated. They were used to evaluate the diagnostic accuracy of MTB Ultima and MiniDoc MTB using both swab types against sputum liquid culture, and then also against the sputum expert MTB RIF Ultra and spear microscopy. The sensitivity and specificity is on the slide, but what is the most important point here is that the research found that the oral swab samples with MTB Ultima and MiniDoc have similar accuracy to current sputum-based molecular tests with sputum swabs. And they meet the minimum accuracy threshold for non-sputum near point-of-care molecular test, providing the robustness and accuracy to this particular test. So basically, what I'm trying to say here is that they meet all the standards to increase the diagnostic yield. They are showing the robustness and accuracy that is required of a diagnostic test, and making these tests extremely promising. So those are the big updates ever since Morton's presentation. So thank you so much.
Thank you so much, Agrata. We do appreciate the updates that you have given us. And yeah, we will, just a note to remind us that we will be sharing with you the slides and the presentations. And please be sure to pose your question in the Q&A chat. But at this point, I'll just open up for 2 questions. 2 to 3 questions for those who may want to unmute and, pose their questions to all the panelists that we have, those who have spoken so far. But we do have 2 more panelists who would also be happy to respond to some of the questions. So I'll pause here and look out for any questions. Please feel free to either unmute and speak or put up your hand. So Vama, I hope I'm pronouncing your name right. Vama, please proceed.
You are pronouncing right. Thank you, my lady. And thank you so much to all those presented here. And it actually gave us hope for 2030. And not really hope, but it makes us to have that confidence that in 2030 we'll be able to make it. But on my side, I'm trying to look at the issues of TB, especially focusing on TB in the mines. I can see that there is something that has been awaiting as a presentation to come, of which I also posted some question on the question and answers. And I can see that there are some few comments that came from some couple of guys, which is very good also. But what I would like to say is that we would like to see more focus. Probably we are focused so much on HIV, but we would like to see more focus on occupational lung diseases, which is more contributory for TB burden, especially in those countries that are mineral rich. And bear in mind that those are the target countries that we also would like people who do the research to also cover them. But it's not a question, but it's just a comment. Thank you, my lady. Thank you, Program Director.
Thank you, Vama. And indeed, like we mentioned, we encourage all those comments to come in as well. Please feel free to post them in the Q&A chat. Yeah, we welcome them too. Thanks, Vama. If we have no other hand, I will move on to our next speaker. And at this point, we are getting into the country case studies. We want to find out, we've heard from Alexi, we've heard from Tapiwa, the updates at the global level, at the regional level. But then what does testing scale up in Zimbabwe and Malawi look like? So at this point, I'll call upon our colleague and friend, Donald Tobaiwa, to talk about the Zimbabwe case study.
Thank you very much, Alice. I hope you can hear me.
Yes, we can hear you, Donald.
Yes, my video is playing funny items, but I think I can speak to my presentation. Next slide. So I'm speaking from Zimbabwe, and I work for Joint Hands Warfare Organization, an organization that spans across health, social development, disaster risk management, climate change, and strategic information. It works in the both from the grassroots up to global level in terms of bringing, operational issues, programmatic issues into policy level issues, but also practicing them in the ground. The next slide. So in terms of speaking to the diagnostic gaps, I always want to look at the TB journey. As a person engages with one of the major challenges, which is stigma along the TB journey, you would find that there are 2 elements, and these components do affect how we get into the TB space, from screening up to seeking care, up to getting accurate diagnosis, beginning treatment, treatment adherence support, completing treatment, and then post-TB treatment care, which is critical. But along the journey, we also find the major barriers, one of the major barriers being stigma, and it also happens at the diagnosis level. Next slide. So in terms of the current TB diagnostics landscape in Zimbabwe, we have a total number of government health facilities, 1,650 in total. These are primary health care facilities, both in the rural and then the urban and peri-urban settings. We have 188 gene expert machines in the network. We have 18 out of the 188 are gene expert XDR machines. We have 3 line probe assay sites in the country. We have a total of 20 TrueMat machines in the public sector, and we have 61 new digital X-ray machines in the public sector, including 14 mobile digital X-ray machines that were deployed in 2023. So this is the current landscape according to our NTP. Next slide. So the US government, just like all other presenters presented, has had a major, issue in terms of the effects on screening and diagnostics services in the country. You'd find according to the screening activities, 38% disruption happened in both active community and passive facility-based TB screening. And the consequences now is long waiting times, increased healthcare worker workload, higher out-of-pocket costs for patients. So our catastrophic cost survey that was done in 2018 indicated that patients were incurring 80% catastrophic costs, and that was before the USG stop work order. And now with the stop work order, it's even worse. Increased missed TB review dates and medication pickups, reduced patient flow due to halted community outreaches. And in terms of diagnostic services, there's been 100% disruption in laboratory reporting forms and personnel. Lab scientists, microscopists, riders were all affected because they were supported by US government and partly supported by Global Fund. And then critical shortages around gene expert cartridges. We are coming out of that gap currently, where we had a serious gap. So 5% gaps that we had during the period when the stop work order started in January. Then in terms of TrueNat reagents, 5% sputum cups, pre-existing stockouts as we speak. And delayed turnaround times, 3 to 7 days, as opposed to 1 or 2 days that was previously there, because we had integrated sample transportation, and we also then have specimen transportation disruptions because of that gap. Next slide. So be it as it may, the Zimbabwe Epidemiological Review, the 2022 one, recommended that there is need for renewed efforts towards finding missing people with TB, targeting high-risk groups such as minors. And I'm happy Vama also sent this appeal. So these are among some of the target high-risk populations, with Zimbabwe having more than 1 million designated small-scale minors. And these high-risk communities were part of the recommendations that came from the epidemiological review. But at the same time, you would find from the current data, as at August, we then realized that we're missing about 35,000 people. But in response to this, Joint Alliance has been implementing the integrated peer-led program among high-risk groups, including minors, sex workers, youths, and TB, diabetes mellitus, co-infected population groups, TB, HIV co-infected, and community TB active case finding, under the theme where we're saying taking diagnosis to the point of need. And I'm happy Morton was talking about the diagnostic equipment that is there. Next slide. So as we started doing that, we then started seeing community contribution towards the national TB notification rate increasing from 8% to 22% across 8 districts where we're implementing a program. And this is as per the districts that are there. I'm not going to go through one by one, but this was as a result of a active case finding approach that was done through 120 community-based volunteers. But then these were trained in IPC, infection prevention control, the ability to be able to collect specimens in the communities after doing screening and all the necessary diagnostics, and then taking those specimens to the facilities for the integrated sample transportation process to then happen to take these specimens to the laboratories. Next slide. And in terms of the integrated snapshot, this is just a snapshot of the integrated program where the PA, these are the other artisanal small scale miners that we've since trained, because it's easy to then use the peers to engage their peers, given that they've limited health seeking behavior. They don't have access to facilities because most of the time during the day they are underground in their pits, in their workplaces. So we have empowered and given these peers, BP machines. We've given them diabetes machines. We have trained them in TB screening. We've given them rapid diagnostic tests for HIV. So they're doing everything using this equipment in the community. So just out of interest, 203 have been tested for TB. 25 of these had high blood pressure, but as you can see lower down, you can actually see the HIV cascade based on the peers that are working. 312 have been reached with services, but out of the 312 through the cascade, you then realize that 5 tested positive, and then 5 then were initiated in treatment. So these are across. This is just an example of Chirumanzi Institute. If you look to your left, diabetes testing 205, 5 with low blood sugar, and then 2 with high blood sugar. But ultimately, you also see for TB testing the same that we engaged for HIV, the same that we engaged for BP, for diabetes, the 312. They then also screened for TB, and then you see eventually across the cascade 2 being put on treatment, and then 2 being notified. That's just an example of that district. But we have higher districts where you find 5 being yields, but we also have higher silicosis that are coming out of this screening, and I didn't put statistics around this, but this is as a result of diagnostics at the point of need, and not in form of outreaches, but in terms of a peer-led program. Next slide. So these are just pictures that demonstrate, you can actually see the equipment on the ground. So we are reducing where a person would then go to facility just for a BP test, where a person would go for an HIV test or TB screening or diabetes. We have moved this to communities such that only the acute then patients will then be referred for management in facilities. Next slide. And this is again an example where if the follow-up then happens at facility, then confirmatory tests do happen. And then as referrals are done, the PA is the one that escorts the other PA to the facilities, and then it becomes quicker and faster for management then to take place. So these are just different examples of integrated screening happening at the point of need. Next slide. So when I indicated that when then specimens are taken, they are then sent to different laboratories, and we as an organization we're also contributing to a public-private partnership. So the Riverdale Health Center serves a community of 7,000 plus small mining community, and this has actually helped in easing the turnaround time. This is a fully fledged laboratory with capacity to process more samples, and it also facilitates viral load. It has increased viral load turnaround time. Also, EIG also helped in terms of the limited CD4 testing that was there, and also helps in terms of childhood TB diagnosis now that we're using this tool. So among some of the statistics, 1,396 samples that were processed using GeneXpert, and then 79 using microscopy, 70 MTB detected, and 19 DRTB detected during the period from the Riverdale Health Center that is run by Joint Adams working with the ministry. Next slide. So as I conclude, we are not missing people with TB, but people with TB are missing the services at the point of need. So the people are there, but the services have to be taken to them. We therefore need to take services to the people. We need to deploy more AI-driven point of care, screening and diagnostics equipment and services. We need to utilize the peer-to-peer model that I have just demonstrated. This approach is more cost-effective and has more yields than using a bigger van. Outreach that then gets to a center that is not where the point of need is. But if you have these smaller point of care machines, you then can go to the point of need, you facilitate screening, you facilitate diagnosis, and then quickly management then starts to happen. But silicosis continues to be a major issue, and an appeal for research and development to find efficacious therapies for silicosis, as well as AI to enhance early detection of silicosis as we're doing TB screening, because late detection then means we're just doing palliative care. We just have silicotics in a concentrating oxygen concentrators, and we can't do much. So we need the big farmers, we need those in R&D to then engage more in research and development around silicosis. But most importantly, integration is key, and the lung health approach is important and is the way to go globally, because we cannot just look at TB in an isolation. We cannot just look at lung cancer in isolation, asthma, silicosis in isolation. We need to look at the lung as a lung health approach, and the world is to use that approach to ensure integration happen at the point of need and at the primary health care. I think I'll stop here and take it back to Alice. Thank you very much.
Thank you so much, Donald. You have shared so much, and let us know the work that Jointed Hands Welfare Organization is doing in Zimbabwe. You have also talked about the need for near point of care TB tests. And on that note, I want to let us know that in our next session, scheduled for 2nd October, at the same time, we will dive deep. We will have more details on near point of care TB tests. Seeing that we are running out of time, I want to quickly go to our last presenter, who is Hari Madukani, who works with the Coalition of Women Living with HIV and AIDS in Malawi. Hari will give us country experiences or a case study from Malawi. Over to you, Hari.
Thank you very much. And I think the name itself says it all about COLA, a Coalition of Women Living with HIV and AIDS. HIV formed in 2006, and we use support groups as entry points. We have a membership of about 60,000 women. Next slide. Yeah, so in terms of the current TB diagnostic landscape in Malawi, TB and drug-resistant TB remain a major public health concern in Malawi. Currently, this is exacerbated by high HIV prevalence rate, which has resulted in high HIV and TB co-infection in Malawi, about 21% in terms of diagnosis, bacteriologically confirmed using molecular tests, which is the recommended WHO way of diagnosis, which means the remainder, around 79%, is confirmed using the smear microscopy. This is a century-old technique that is efficiently accurate, not that recommended, but for resource-limited countries like Malawi is still being used. And then TB testing in Malawi is primarily delivered through primary health centers, which are also called the peripheral health centers, where we do the sputum collection, from the symptomatic individuals, and then the tests are conducted using the smear microscopy, which I've just mentioned. And also in urban areas, like Lilongwe or Blantyre, we have what we call the community-wide active case finding, which is done by mobile digital X-ray vans, and we also have door-to-door symptomatic screening. Next slide. And then TB testing in Malawi happens as follows. So we are the screening happens at 3 major points. We have got the peripheral, also known as the health centers mostly in the rural areas where the screening is done. But it also happens at the district health facility, and once in a while, it also happens in what we call the central hospitals. So TB diagnostic testing, we have the sputum smear microscopy, which I've already mentioned, and is usually performed as the initial TB test at peripheral health centers. And then thereafter, confirmatory rapid molecular testing for TB and the resistance to rifampicin is available through referral. So we normally collect the samples and send them either to the district hospitals or the central hospitals through the samples. And the challenge we have here is the turnaround time, which normally takes a long time. We also have the LAMP testing, TB LAMP testing, which is sufficiently available and eligible to people living with HIV, the pure HIV, seeking care, and is performed according to the WHO recommendations. That is on the initial visit to the health facility. Then another one is the drug susceptibility testing, whereby recipients of care who are diagnosed with TB in the peripheral health centers are referred for drug susceptibility testing using the GeneXpert, which is normally found at district hospitals and a few selected health centers to test for resistance to rifampicin. Next slide. So going into the state of TB diagnostic gaps in Malawi, quite a number of them, but I've selected the main ones or the significant ones. The first one is the failure to initiate testing and lack of symptomatic inquiry, whereby the largest gap is between the clinicians eliciting symptoms. You find that somebody comes to the facility presenting symptoms of the TB, sometimes they are missed or the sputum is not collected. And normally these people degenerate into sometimes advanced TB. So a lot of recipients of care or patients are lost at this crucial point. Also, they have the issue of inadequate laboratory capacity. If you go especially to the peripheral health facilities, there is lack of necessary, first of all, qualified staff and also equipment to perform the quality TB diagnosis. And this leads to delayed diagnosis and the dependence on high-level hospitals. We have had cases whereby recipients of care have been missed at the facility and then they end up at the district hospital when their condition has degenerated. We also have the challenge of trained personnel. We have very few people that have been trained to provide this service. And also insufficient funding for community-based sputum collection points, whereby we are not collecting as much sputum as we would have loved because of issues of funding. And also barriers to new diagnostic technology. The recommended GeneXpert, as I've already mentioned, is found basically in district hospitals and in a few selected health facilities in the peripheral health facilities. And this hinders diagnosis, particularly in rural areas and among vulnerable populations. Next slide. Yeah, so addressing these barriers, this is my final slide. First of all, we need to improve health worker training. This is a very big need. If we can train as many healthcare workers to provide the service, I think we can really do quite a lot in terms of addressing the diagnostic gaps. Secondly is to improve laboratory infrastructure. You find that the very few facilities, the peripheral that I was mentioning, have got the laboratory structure, and even those that are available, they are not fully equipped. Some of them do not even have running water. And then we need also to develop a stronger reporting on the early cascade steps. Once we improve on this, then we can have as many cases as possible being reported and being diagnosed. And also, we need to move towards adoption of novel, high throughput diagnostic approaches and decentralized services to increase testing capacity and facilitate same-day diagnosis, as I already mentioned, because of the issue of transporting sputum or specimen from the peripheral facilities to the district hospitals. We also encounter issues of a high or long turnaround time, and this takes time to offer treatment or to recipients of care. And we also need to revitalize the community involvement and sputum collection points. We have sputum collectors, but often enough, I've heard quite a number of them complaining about incentives. Some of the incentives, including even having gloves to wear when they are collecting the sputum. Some of them could even miss this. So that's another final, I think, barrier that we need to address. We also need to have a lot of partnerships and even incentives to the community volunteers. Thank you so much. These were the few slides that I needed to present this afternoon.
Thank you, Harry. We are so pleased to hear about what is happening in Malawi, the steps that have been taken, but also the gaps that still do exist and what should be done to bridge those gaps. So, colleagues, we are coming very, very close to the end of this webinar today, and I don't want to end it without giving a few colleagues a chance to, ask their questions live. And Stephen, I can imagine your hand must be really tired right now, but you now have the floor to pose your question. Stephen, are you there? If Stephen is not there, we could go on to the next question. I know that lots of questions have been in the chat, in the Q&A chat, but if anyone would like to ask their question and get an answer live, please feel free to put up your hand and we will unmute you. All right, so looks like we don't have questions right now, but I know that the panelists have been very busy responding to a couple of questions that have come in. So at this point, I want to call on some of the panelists to possibly stress some of the responses that you have been providing in the chat. And thereafter we will proceed. Alexi, would you want to come on?
Yes, thank you, Alice, with pleasure. First of all, thank you for all questions. There were multiple, and I really enjoyed reading them, showing a high level of understanding, also of importance of all these aspects. There were several, probably I could group around using tongue swabs, first of all. The question was why they are so important, why they are better than sputum. They may be not so better, but they are much easier to collect and potentially can be collected by a person himself or herself. It's also sputum can be collected, but it's sputum collect is not easy. Indeed, we always say it could be collected in the morning, right? But I mean, it requires effort and some skills. Much less for tongue swabs. Another group on point of care testing, why it is important and which are recommendations and how to compare point of care with some recommended molecular tool. Unfortunately, regarding point of care, there is only one test recommended by WHO. This is LF-LAM. LF-LAM, which is urine test, which is useful in HIV infected patients, but also very sick in HIV-infected patients. But by these qualities and characteristics, it is very useful test and very good, but also use it very limited. So why there are no, I mean, they are in development, but unfortunately we are not there. Yes, and also why tests why molecular tests are less effective for extrapulmonary TB is just nature of disease, and there are less bacteria there, and there are limitations. But it is still possible for some tests and for some specimens, extrapulmonary specimens, to be used. I stop here.
Thank you.
If I can continue also for the sake of time.
Yes, indeed. But we do appreciate the responses that you have provided in the chat, as well as the very well received presentation. I'm sure I know that we will get some questions online as well, and we will be sending those your way so that you can respond to them.
Alice, can I come in?
Yes, sure, Sharon.
So I just want to point out that the near point of care that we have referred to many times, that is available or soon to be available, Plus Life, was approved by the Global Fund Expedited Review Diagnostic Panel. Also, I'd like to point out that WHO is convening its guidelines development group and will be reviewing the data around the near point of care test later on this year. So this is a very live issue and one that we'll continue to report on and bring you some of the evidence in our future webinars. Thank you so much, Alice.
Thank you, Sharon.
Thank you.
Colleagues, as always, it's really hard for us to say goodbye, but we have to say goodbye at this point. We know that we will be seeing you again on October 2nd, when we will have the second part of these webinars. And we will dive deep into some of the issues that we have left out today, much more. Otherwise, until then, please feel free to join the deck listserv. You can write to that email address. We will be happy to include you, send you updates, send you presentations, and anything diagnostics. We will be happy to share that. Thank you so much, and see you on October 2nd. Bye.